It is really exciting for me to introduce Dr. Ali today, Dr. Farhana Ali, that I'm sure a lot of you, if not all of you, have worked with up to this point. So she is currently completing her advanced nutrition fellowship with us, and we're sad that she's leaving. We're doing our best to slow down time so that she can stay with us as much as possible. But I think she's had a very productive year. And just looking at her CV and what she's done, I am actually amazed that she moved to Cincinnati after having spent so many years in California doing her training. But we're all very thankful that she did. So after having spent many years training there and finally doing her GI fellowship at the University of California, San Diego, we were fortunate enough to recruit her. And I will say that I do remember reading all the information that she had sent us when we were reviewing her application package. And I remember getting chills reading the letters of recommendation that people had written for her. And people were not lying. It's been an absolute pleasure working with her this year. She will be moving to the University of Utah, where she'll start as an associate professor there and help them build a nutrition program. And we're excited to collaborate with her from afar. But today she's going to talk to us about the work that she's been doing with a lot of people, but primarily mentored by Dr. Kalkworth on bone health of children with intestinal failure.
Okay, thank you, Marilena. And thank you guys for letting me be here. This is actually going to be the first time I've had the opportunity to present these research findings. So every fellow has to come up with a research project during their training year. And I opted for something that pertained to the shortcut kind of intestinal failure population, and decided on looking at bone health using Dexa scans in these children, and how their bone health kind of changes with time. I'm gonna hide my face because I can see myself, but I will turn it back on at the end. Okay, so this is just gonna be the learning objectives that I'm gonna use to kind of direct the PowerPoint. The first one is gonna be to review the current understanding of metabolic bone disease in children with intestinal failure who are on long-term parenteral nutrition. Number two, to assess the longitudinal changes occurring in their bone mineral status in these children, and then to review the impact of short stature on bone status in children with intestinal failure. So what is intestinal failure? It's basically an umbrella term to encompass clinical disorders that result from the loss of the intestine's ability to properly absorb. And this then lends the intestines now unable to properly maintain balance when looking at fluid, electrolytes, and energy. By definition, intestinal failure is going to require the need of parenteral nutrition to help sustain normal growth and nutrition. Depending on what society or what literature you read, or looking at adults versus pediatrics, that time duration can vary. But in sticking to the National GI Society for NASPGHAN, as well as with the Pediatric Intestinal Failure Consortium, we stick to this definition of needing PN for at least 60 days to then qualify. For IF, there's a wide variety of pathologies that result in intestinal failure, which I'll go into in the next slide. But for the most part, the majority of the insult or the condition occurs at birth and early infancy. And for management of this population, one, it's going to be providing them adequate nutrition using PN, but it's also trying to restore bowel function. What's really amazing about this population is that their intestines undergo this like adaptation response, where it's both a figurative as well as a physiologic change, where the intestines try to compensate and improve absorption of nutrition. And as that process progresses and kind of goes towards something that's more normal, then the need for TPN actually lessens and they start to get weaned off. When thinking about pediatric intestinal failure causes, kind of think about them in three big groups. One's going to be short bowel syndrome, then dysmotility disorders, and mucosal enteropathy. Short bowel syndrome is going to be either a congenital or an acquired reduction of the small bowel length. So something had made you need to cut the intestines out, or the intestines, the surface that they have, it's just it's losing its ability to properly absorb. There are different causes for short bowel syndrome. The most common for short bowel syndrome is going to be neck or necrotizing enterocolitis. And it's just important to note that amongst the causes of short bowel or of pediatric intestinal failure, short bowel syndrome is the most common, and neck is the leading cause of short bowel syndrome in developed countries actually. I have a few pictures to give examples of causes of short bowel syndrome. The first one is neck, which you guys are probably familiar with, but you're going to have some sort of damage or death to the intestinal cells, and that's from an underlying infection or inflammation. It's typically seen in the premature infant population. Gastroschisis and omphalocele are going to be examples of abdominal wall defects, where in utero, during fetal development, the intestines actually don't go back into the abdominal cavity. So the kids are born with part of their intestines outside. And then you can have intestinal atresia, which is another sort of insult that occurs during fetal development. And you get a defect in the intestines. So if you were to think about the GI tract as being this like continuous tube, something's gonna, there's some sort of insult that kind of disrupts that continuity, and the intestines are either there's some sort of stenosis or a narrowing, or doesn't fully develop. Dysmotility disorders are going to be abnormalities in kind of normal contraction of the muscles in our GI tract that propel contents forward, which we know as peristalsis. And the common disorders that you guys are probably familiar with are going to be Hirschsprung's, as well as pseudo-obstruction. Hirschsprung's is going to be you're missing the nerve cells in the lining of the intestine, so you don't have proper kind of function or contraction of the intestines. And then pseudo-obstruction is going to be this abnormal dysregulation in the peristalsis, which again also leads to kind of discoordination in normal muscular contraction. And then mucosal enteropathies, these are going to encompass kind of when we think about the other disorders outside of small or short gut syndrome. And these will be any sort of underlying inflammation in the GI tract that leads then to malabsorption or diarrheal diseases. Now, TPN, as we all know, is going to be a mixture of components, both macro and micronutrients, to provide as much of full nutrition as we can. For kids who are on TPN, we're actually able to categorize them based on their PN dependency as an index. And that is expressed as a ratio using their non-protein energy needs from the PN, and then comparing it to their resting energy expenditure, which is extrapolated using the Schofield equations. And these are kind of the three big groups that children on TPN can be categorized into. If you have a ratio for your non-protein energy over the resting energy expenditure, that's less than 80%. They're deemed to be kind of mildly dependent on PN. Anything more than 80 or 120% puts them in the category of being high dependent or very highly dependent on PN. And the reason why that's important for us to know is it gives us an idea of how severe their needs are when it comes to nutritional support, but also guides us as we start to wean them off to see how we're doing in terms of what they're still requiring. So with the advent of TPN, it's been amazing in that it provides, it's provided these improvements in nutritional care, and these patients now are able to live longer. but it's also then brought up kind of new challenges, which have led to then certain morbidity as well as a few mortalities that we have to pay attention to. The common ones are going to be things pertaining to line complications, so either a central line associated infection or blood clots or thromboses. And so these kids are going to need TPN. They're going to need a line which we are introducing. And so now this becomes a nidus for infections as well as for clots. But then we do things to kind of minimize some of those complications, which includes kind of being thoughtful about the line that we're going to choose on them, doing a lot of education for the parents and families on proper line care, as well as being diligent as well as timely when you either suspect an infection or you confirm infection with the use of antibiotics. Sometimes if there are a lot of infections that the patient has been subjected to, then you can use things like alcohol locks to kind of help preserve the line. We also see liver disease associated with PN, and that's not all entirely due to the PN itself. It's a little bit multifactorial. The underlying disease is also going to contribute. We know that TPN is hepatotoxic from some of the components when you think about the soy-based lipids, as well as delivering a lot of glucose. But with this population, you have kids who, based on how much intestine was resected, they have limited reabsorption of things like bile salts, which we know can contribute to cholestasis. Their gut barrier function is decreased, so that it makes them prone to bacterial translocation, and then you get these bacterial toxins in the liver, ultimately causing injury. So when we think about ways to want to prevent that, we're mindful of the composition of the TPN that we're using and thinking about ways to shorten the duration that they're on and working to kind of getting them off. And the last kind of big morbidity that we think about is metabolic bone disease. And this is really the question that we were focusing on with this research, is to kind of understand what is going on when it comes to their bone health, and are there things that we can do to kind of help minimize or prevent progression of bone disease. Before I go into what metabolic bone disease is, I thought it'd just be helpful to do a quick overview of anatomy of the bone, of normal bone. So bone tissue differs from all the other tissues in our body because it's hard. And that hardness actually, though, is what we depend on as a characteristic for its function. And bone, as we know, is a connective tissue which contains a few cells, but a large amounts of it is this extracellular matrix. And this matrix is really what puts bone together. It's going to be made up of both organic materials, that's going to be the collagen fibers, which provides kind of a scaffolding surface, as well as these inorganic materials, which are going to be your salt crystals. And the crystals then are able to adhere to the scaffold surface to then calcify. And together the two provide both this stiffness and hardness for strength, but it also provides some flexibility without the bones being too brittle. And it's important to have both, because if you remove or have less of one component or the other, then you get some sort of derangement then in the bone health, which then leads to metabolic bone disease. This is going to be another umbrella term, which is going to encompass conditions that cause changes in the bone structure, strength, and it's usually due to a mineral deficiency, that being your calcium, phosphorus, magnesium, or hormonal imbalances from vitamin D and PTH. The two metabolic bone diseases that you guys are probably familiar with are going to be osteomalacia and osteoporosis. So osteomalacia is going to be when you have defective calcification of the bone osteoid, and that then leads to poor mineralization, and the bones then become weak and soft, and so they start to like change their shape, and then they can bow, which is that picture on the left. Osteoporosis, on the other hand, is when you have a decrease in the total amount of bone in mass and in density. The composition of the osteoid and the mineral, though, can still be the same. And when you have loss of bone mass, that now makes bones brittle, making them prone to fractures. When you look at adult literature, there's plenty of studies that show this kind of clear association with long-term PN use with metabolic bone disease. If you were to look at their imaging scans, you can see that their bone density is low. If you look at histology of bone, you can see that there's reduced bone formation. And then when you look at labs, you can see that their bones are kind of leaching calcium and they're excreting it in their urine. And the pathogenesis for metabolic bone disease in adults on chronic PN is more multifactorial. You know, it's related to malabsorption of the minerals, but also having inadequate mineral stores, as well as some of the toxicities that we can see with compounds in TPN. In pediatrics, you know, we see metabolic bone disease, but that clear association is not there. And a lot of that is because the studies that we have looking at pediatric intestinal failure and chronic PN exposure, it's much fewer. And the studies that are done are heterogeneous. So sometimes the findings are not as comparable or they're just not as strong. So how do we assess bone? During growth, we know that our bones increase in length and width, but it also increases in cortical thickness. And so that's what leads to an increase in bone mass, which is our bone mineral content, and an increase in the bone mineral density. We have bone tests, density tests, that can give you a snapshot into bone health, and it's going to be measuring your bone mineral density. The clinical standard for this measurement is going to be the Dexa scan. And in pediatrics, the bone density is going to be expressed as Z-scores, and that's because we want to make it relative to children of the same age, sex, as well as race. So here is an example of a Dexa scan imaging that you may see. So the Dexa scan utilizes two energy wavelengths. You have low energy and high energy to then discriminate between soft tissue and bone. And we have different scan types that are available to obtain. So within pediatrics, the recommended imaging modalities are going to be the lumbar spine or the whole body spine, and that's because they can provide reproducible measures of BMC and BMD. When you get a Dexa scan, it will give you certain information. It's going to provide you measurements for bone area, bone content, and then it can then calculate the bone mineral density. And what's important to note about the Dexa scan is that this is a two-dimensional measurement, which means it's not going to provide you information about bone depth or volumetric density. And the reason that's important to note is because that will lend the Dexa then subject to side-related artifacts. So something that's smaller, the volumetric density may be the same, but its bone mineral density will actually look lower. And so you need to account for this when you think about smaller bones or when you think about kids that are short and who are small for their age. And this is why it's really important then to account for short stature. So that way you aren't kind of overcalling the prevalence of lower bone mineral density in kids that are shorter. We do have position statements that kind of define different bone assessments, both in pediatrics and adults. These statements are outlined by the ISCD, which is the International Society of Clinical Densitometry. And how the ISCD defines low bone mineral density is going to be looking at the Z-scores. So if you are at a Z-score of 2 or below the mean, which means you're minus 2.0 or less, then you are considered to have low bone mineral density. Anything above minus 2.0 is actually still considered to be within expected range. We also have definitions for osteoporosis. That's going to be different from the adult definitions. There are kind of two ways that you can define pediatric osteoporosis. One's going to be if you have the presence of some sort of some sort of crush fracture present in the vertebra. And this is going to be a fracture that has to be in the absence of trauma or local disease when you think about malignancy. Or you can be diagnosed with osteoporosis if you have some sort of clinically significant fracture plus a low Bmd score, so that being -2. And they have their own definitions of what is considered a clinically significant fracture. That's going to pertain to the number of fractures in a long bone that's incurred at a certain age. In adults, they're able to better kind of ascertain the probability of a fracture based on the T-scores, but we don't have that same luxury in pediatrics. So it's important to note that you may have a Z-score that's quote unquote within like the expected range of age, but that's not going to preclude the possibility of an increased fracture risk or skeletal fragility. So now we can kind of talk about what have they done in terms of studies looking at metabolic bone disease in kids with intestinal failure, and what have these studies taught us. And really, when you look at the last 4 decades, there are few studies actually looking at bone density in kids with intestinal failure on prolonged PN. It's about less than 2 dozen. And overall, these are going to be small studies. The median number of participants is usually around 19. And that makes sense because in general, intestinal failure in pediatrics is not necessarily a very common disorder. And so within regions, you're not going to have large populations or large numbers of these kids. When you do look at these studies, there's considerable variation in the definitions that they use. And this is going to be definition both for intestinal failure, which goes into what they deem as the cutoff duration for PN, but also in the definition that they deem as low bone mineral density. The Z-score cutoff isn't necessarily always in accordance with the ISCD. Sometimes they'll use a Z-score of -1 to mean somebody has low bone mineral density, but that can again overestimate, or that can give you overcall the prevalence of lower bone mineral disease. And then when you looked at studies that have utilized Dexas, most often they didn't adjust for the anthropometric measures that we talked about, being height and short stature. So which lends us to what we wanted to do differently when we were deciding on our research project. And our aims was, one, we wanted to look at the changes in bone density over time using Dexa, knowing that that's the gold standard, and using the same scan type in these children, so that way we can do a longitudinal analysis. And then to see if we can identify predictors of changes in the bone density. The outcome that we focused on is the Bmd Z-scores that were adjusted for height using their HAZ scores. So we did a retrospective study looking at kids with intestinal failure using the definition of a minimum of 60 days for PN need. And the time period that we did it in was about the last 11 years. We wanted to focus on kids who had a diagnosis of intestinal failure under the age of 3. And a large reason for that is because we wanted to capture the kids who get their insults in early infancy. And also because by the age of 2, most of your GI tract has developed and grown. And so we wanted them to be comparable when we thought about our population of study. We looked at kids who had 2 or more Dexa scans, and that was so that way we can do a longitudinal approach. And that first Dexa scan, we wanted to make sure it was under the age of 10 because we didn't want puberty confounding our results. And then we looked at a slew of potential predictors for bone mineral density. And we looked at these, we looked at all of these different aspects using a time period of 3 months prior to a Dexa. So we collected lab information looking at vitamin D, calcium, phos, and bilirubin levels. We also took data of their nutrition history, looking at both parenteral as well as enteral nutrition in terms of what are these kids on, what's the duration, and then what are the components of their macronutrients. When we went through our study selection, ultimately we ended up with a sample size of 34, which isn't very high, but isn't necessarily unexpected. A lot of these kids, they didn't meet inclusion criteria when you took into account the definition of intestinal failure for TPN for a minimum of 60 days. But we also excluded a number of kids that we felt didn't meet the proper definition. So, we wanted these kids whose intestinal failure was related to intestinal dysfunction and not because of some other primary non-GI disorder. So kids who were BMT patients needing TPN were not included. The mitochondrial disorder kids or kids with underlying neurological disease were left out. So what do our subjects look like, the ones that we did end up including? So the median age that these kids were diagnosed with intestinal failure was 2 months, which means that the onset of their insult was at birth. The distribution of their sex was equal. You had 50% male, 50% female, and 76% of the participants were born premature, with the median gestational age being 35 weeks. We also were able to determine the kind of median TPN duration, and these kids were on TPN for about 4 years. When you look at the different diagnoses associated with intestinal failure, the participants could have more than one diagnosis, which is why the percentages are not going to add up to 100. But when you look at the top 3 diagnoses, they're in line with what we see nationally, and that's going to be gastroschisis, atresia, and neck. When looking at the anatomy of their bowels in our study population, the majority of them, 85% of them, had some sort of small bowel resection. And then 88% of them had their GI tract in continuity, which means that after they had some sort of bowel resection, they were put back together, they don't have an ostomy. We also wanted to look at how much small bowel length that they had remaining, and that's important for us to know, so that way we kind of know what we're dealing with when we think about these kids in terms of how they're going to progress in terms of their adaptation. And then we also wanted to look at how much colon they have grossly, as well as the presence of an ileocecal valve, which is going to be that valve right at the end of the small intestine at the start of the colon that kind of helps the reflux of colonic bacteria into the small intestines. And then a few of these patients end up going on to needing a small bowel transplant. So we were able to track those that were small bowel transplant recipients, and they were about 21%. So now we got to see how many Dexa scans our patients had and at what age they were done. And what you see here is all subjects had at least 2 Dexa scans. Once you got to those subjects who had more than 2 Dexa scans, the sample size drops down quite a bit. But the median age of the kids was about 3.5, when they had their first DEXA scan done, which actually isn't terrible when you think about so all of the subjects actually had lumbar DEXA scans, and we know that the lumbar DEXA is reliable for age 3 and above, but it also takes time for us to be able to kind of see changes in bone health and with kids kind of cooperating with the scan. So this isn't out of line. What you see here, this is going to be the patient's disease scores at the different DEXA intervals, and you can see weight, height, and BMI Z-score. When you look at the weight and you look at the BMI Z-score, what you see is that it's not terrible. Like their weights are about maybe half to 1 standard deviation below the mean, which is still normal. But when you look at their BMIs, it's above. Those are all normal. What I wanted to point out is when you look at their heights, though, these are kids that are short. Their standard deviations are usually 1.5 below the mean, and this is consistent throughout with time, so it's not getting better. We wanted to explore some of the clinical characteristics in these kids. So what you see here is a graph of the percentage of kids that had a central line infection. And overall, the percentage of central line infections wasn't very prevalent. At the time of first DEXA scan, about 26% of the patients had some form of line infection. These are usually just one line infection. They're not having more than one. And with time, you see that percentage goes down. And that's really a testament to what we're doing in terms of kind of preventing and minimizing line complications. Here is a graph that looks at kids who had concurrent cholestasis being defined as a direct failure of more than 2. And overall, cholestasis isn't something that we see in our study population. Less than 10% of the kids are cholestatic. And again, that's really a testament to the intestinal rehab team being aggressive and making sure that they improve their cholestasis or that these kids aren't getting cholestatic. Here, we are looking at vitamin D status in terms of those who are deficient versus not deficient. Deficient is going to be a vitamin D level that's less than 20. And then sufficient is going to be more than 30, and insufficient that is in between. And what you see here is that for the most part, the subjects at large are not vitamin D deficient. Yes, about less than 10% of the subjects at the time of DEXA 1 are deemed to be deficient. But when you look over time, the percentage of those who are not deficient goes up quite a bit. What you don't see here that I didn't show for the results is we have the median ranges for the vitamin D levels at all of the DEXA intervals. And at each interval, the median range was about 29.9 or roughly 30, which again puts them above the range that you would think for deficiency. And while our goal is to have them be in the sufficient range for bone protection, we really just don't want them less than 20. What you also don't see here, but we do have, is we were able to get the median ranges for the serum and BOS levels, and at all of the DEXA intervals, we found that their levels were always within the normal ranges, and that was even after correcting for calcium levels if albumin was low, which is just more reassuring. This is a graph that looks at the percentage of subjects that were on TPN at the time of DEXA. So at DEXA 1, you see that 53% of the subjects were on TPN, which means nearly half were already weaned off. And as you go on with time, you have less subjects who are on TPN, which again kind of speaks to the kind of proactive and aggressive approach we take in trying to wean them off. This is looking at subjects based on their PN dependency index. So the green line is going to be those subjects who fall into the mild dependency category, and then blue and orange are going to be those subjects who are high or very high dependent on TPN. And what you see is at the time of Dexa 1, the majority of the subjects, their PN needs are in the mild dependency. And as you go on with time, the percentage of those who are in the mild PN dependency just goes up. So by the time you're getting to Dexa 4, the subjects that used to be in the high or very high range have come out of that range and actually are now deemed to be just mildly dependent. Now we start to look at the BMD scores, which we got from the Dexa scans. The blue, you have blue and you have green. The blue are going to be the the Z scores that we didn't correct for height. And what you see is their BMD scores are reduced. Remember, they're one about a standard deviation below the mean, but they're also not terrible. They're not consistent with low bone mineral density, which we know means a score below of -2.0. However, once we adjust for their height, what sticks out is that their BMD scores improve everywhere. And so that's important to note because we know these are kids, we mentioned that they're short. And so while their BMD scores unadjusted may look reduced, once you correct for their short stature, their bones look fine. This is looking at the percentage of kids with low bone mineral density. So again, that means that their BMD scores is a -2 or lower. The orange is not adjusted for their height. The green is going to be once they're adjusted. So when you don't adjust for their height, you see, okay, about 32% at the time of Dexa 1 had low bone mineral density. But once you adjust for that height, it drops about half. So you're seeing 15% having low bone mineral density. And at the end of, by the time they get to Dexa 4, we're not seeing any bone mineral density or low bone mineral density. We use spaghetti plots to kind of be able to see the trends in the BMD Z scores. And so what you're seeing here is the height adjusted BMD Z scores, looking at kids who were transplanted versus the non-transplants. And what I want to point out is that for the most part, the majority of the kids stay within the expected range. They're between -2 and 2. The few that start off low, with time, they actually end up coming though within the expected range. Really just one stays low. And interestingly, the small bowel transplant kids, their BMD Z scores aren't any worse, which when you think about all the immunosuppressions that they're in, you may wonder, you may think you would have expected them to be lower. We also looked at BMD Z score trends, looking at diagnoses. We kind of categorize them as the neck versus non-neck group. And that's because we know within pediatric intestinal failure, if it's due to neck, usually those kids have worse outcomes. But what you see here is that the neck kids, who are the orange, their BMD scores aren't any worse than the non-neck kids. We then looked at prematurity to see if there was something that we can tease out. Again, since the majority of the subjects were actually preemies, the purple is probably what's going to stand out more. This is your non-preemie kids. And what you see here is the subjects who were born term, their Z scores, BMD Z scores actually always stayed within the expected range. So that kind of brings me to like the end of our study findings. We still have some multivariate analyses to do, But in summary, we're seeing that, at least from our cohort, we have subjects who are born premature and they're diagnosed with intestinal failure about the age of 2. Our subjects are not necessarily battling with vitamin D deficiency or cholestasis, but our subjects are short with a height Z-score that's below 1.5 standard deviation from the mean. And those subjects, when they, while they may have a low BMD Z-score, those scores improve once you adjust for height. And that is the conclusion. These are my research mentors who I've worked very closely with for my project. And then I have my scholarly oversight committee members. So I just want to thank and acknowledge both Heidi and Lindsay. I see them probably on a weekly or bi-weekly basis, but also Conrad and Marilena, who are from the GI division, and Hallie, who's from endocrine, who have been helping me. And then just from this past year alone, my training has been supplemented by many educators. And so I can't thank everybody, but I wanted them to know I'm appreciative of all their help and guidance. Any questions?
Great, thank you, Dr. Ali. We can open it up to questions. If you please, let's see what time we have. Well, I think we have a decent amount of time. I'm gonna take a chance here and go ahead and say, if you have a question, why don't you unmute yourself and ask the question? If it gets a little out of hand, I will dial that back in. So anyone have questions?
Maybe I'll ask a question to get the virtual room going. This was a great presentation. Thank you so much. My question was, were you expecting these results when you started? Were you surprised by this? And as you're thinking about putting this together, like what, why do you think you got these results?
So originally, we were surprised, I would say. The term was probably more like disappointed in that we were hoping to see something novel and that we were going to figure out why. The fact that these kids, their bone health, they're reduced, but they're not terrible. And once you correct for their short stature, they look fine. So it makes us wonder, is TPN really as bad as what we're thinking it is? Or is there something else in their underlying intestinal failure history that's kind of contributing? Are these kids, are they small from the beginning? And do they stay small? Like once they hit puberty, that would be something cool to know. So we were surprised in that nothing stood out. But that's not necessarily a bad thing, is what Heidi also and Conrad keep saying. It's probably a testament to then how well we're doing with management. We thought we would see more vitamin D deficiency, or we thought we'd see more cholestasis, and we didn't. So it was a surprise, but it doesn't necessarily have to be a disappointment.
What other questions?
I want to reiterate that it's really nice for these kids to not have one more problem to worry about, because they've gone through a lot. So the fact that it was, once we addressed their size issue artifact in their Dexa scan, their bone health does not appear to be alarming. And so that is really a good thing, because you don't want to have to start going down bisphosphonate pathways or any other kinds of interventions if it's not needed. There were a few people who were outliers, and it doesn't mean that all kids are going to be fine and we should stop looking at their bone health. And so doing periodic screening of bone health is probably still warranted in the younger kids to identify those who were low, because there's a few kids who are pretty low. And it probably will take a multi-center study to get a large enough sample size to really delve into who are these kids with really bad bone health. And then the other thought I keep having is, why are these kids so small? I mean, and are there consequences of that we haven't thought of?
Thanks, Heidi.
Dr. Cole, did you have a question or comment? You're muted.
Yeah, I like hearing myself. Farhana, great presentation. Thank you for doing this. I think there was just one a question, probably a comment after you answer, but the question is that you brought up the issue about the artifacts, right? And I think a large portion of these patients are G-tube fed. And so how do you think we should address this in terms of if we want to have a good evaluation, especially with the smaller kids where the G-tube is almost half the size of their, of their body. So how do you think we should address this and, coming up with, sort of like appropriate evaluation of their bone health? How would you think, you would advise based on this study or, maybe recommendations that you might give?
You are right. I would say the majority of our subjects had some sort of feeding tube actually present during their Dexas. And so those artifacts, kind of background, we are going to be looking to see how those artifacts affect the BMD results that we get. They actually end up kind of making the Bmd scores look better, or I can't remember if they look better or worse, but ultimately to kind of take out that confounder. All of these subjects had lumbar DEXA scans, and what really would be better to remove that sort of discrepancy with the artifact would be to use whole body measurements at the age of 3 rather than what we're doing now to kind of circumvent the G-tube that is present. Sometimes it's the G-tube, but it could also be the central line that's coming into the field of view. We probably had one subject out of the 34 that had a whole body scan, and a whole body scan that was done longitudinally. And the way around it would be to try to push and get whole body scans instead.
Yeah, thanks. I mean, I don't know the difference in cost. I mean, most of these are covered by insurance. Just wondering if, sort of like we change practice, right? The whole idea of this is try to improve, what we're doing. Does anyone here know, like, if there's a significant cost between a lumbar versus a whole body, or it doesn't really matter?
It's the same.
Okay, thanks.
Yeah, I don't know. I'm not sure. I look at a lot of Dexas that are obtained throughout the hospital, and I'm not quite sure clinically when the lumbar spine versus the whole body will be more useful for your patients. I think that the whole body results oftentimes I see are low, and I think that seems to reflect the relative degree of sarcopenia that those patients have. And even patients who have a low total body bone mineral density seem to have preserved lumbar spine bone mineral density, just knowing that the types of bone you're evaluating with those images are different. And so then I think you just need to be careful how that falls into your interpretation when you kind of change the way that you evaluate it. I mean, I think clinically, my personal opinion is that the lumbar spine DEXA is more clinically useful than the total body. I mean, I guess I would put the question back to the intestinal rehab docs and say, like, if you got a lumbar spine DEXA and a whole body and the lumbar spine was normal and the whole body is low, would you change course with anything? Or like, how would that impact your clinical care?
I think maybe one would be more aggressive, right? If one of them is slow, especially if we know that there's an artifact that might impact it, with the central line, especially the younger babies. I think if they're older, then you can subtract that area, right? But the small 3-year-old, I mean, we'll just have to think about like what's the size and how that impacts it. That's probably going forward. And like we said, serum vitamin D alone is not ideal. We're doing a good job in keeping that. It's one of our process or measures that we look at pretty frequently. The other things that are responsible for bone health, we don't look at much, like activity or how much, whether they're ambulating or not. I mean, these are things we really don't truly address. And those are important factors for bone health. We don't address those at all. I mean, we address maybe aluminum toxicity and other things that might impact, the other minerals, but we really are not looking at factors outside of that in these patients.
Yeah. And I would say if the patient has a G-tube that can be removed, I mean, they can just take that out for the Dexa. That would be, I think, the biggest thing that would be amazing to do. That would solve that problem.
Yeah, so that might be something we have to think about as well, right? Put an order in, and the people in the Dexa room can't do it. We'll have to talk to the families to do it, and say, just before the test, probably have an order and talk to the parent when they're coming in and say, this is, a 3-minute or 5-minute study, take it out immediately after you put it right back in, and we could educate and work with them. So again, these are the reasons why we do these studies, to learn a little bit more, and this information is useful for us that will impact practice and outcome for our patients.
Conrad, the ISCG recommends both the whole body and the spine, and I know many times both are ordered because they do tell you different pieces of information. So the spine measurement is very important when you have glucocorticoid exposure, because you're going to see changes very rapidly in the trabecular region of the spine. The whole body scan, as Sarah mentioned, can be correlates also with lean mass. And part of it is, as you mentioned, if the kids are not as physically active and they're not having as much weight bearing on the bone, you will see an impact there. And so the leg bones comprise a good chunk of the skeleton. And so if kids aren't walking, running, and playing, you're going to see lower bone mineral density in the whole body region that will be impacted on that. So there's different things impact bone in different parts of the body. And so that's why I think sometimes both are ordered to help tease things apart. And as kids grow, so the Mickey button for the feeding tube, it's just a huge impact in the spine. And so even though it's would be still there for the whole body scan, proportionally it's much smaller, and it doesn't have as big of an impact on the measurement.